Well, hello. My name is Jamile Shammo, and I am the director of bone marrow failure at Northwestern University. And today I'm going to be discussing paroxysmal nocturnal hemoglobinuria and speak to the consequences of complement activation as well as available therapies. When one thinks about PNH, triad is classically what we think of, and that's a combination of DAT negative hemolytic anemia together with propensity for thrombosis in the setting of bone marrow failure. This is not a very common disease. It's been estimated to occur or affect 13 to 16 patients per million. And the median age of those patients tends to be in the 30s. This disease can be associated with catastrophic consequences, and given the age of those patients, it's essential that we identify and treat those patients accordingly. Now, granted, there is some degree of variability from one patient to the next, and so we need to identify the exact spectrum of this disorder for each patient that gets identified. But whomever is affected by PNH, this is a disease that simply is governed by complement activation and, in particular, the alternative pathway. So, a few words about complement, since this is a disease that's essentially tied to this specific part of the innate immune system. As many of you know and have learned, that it gets activated by three different pathways. The classical pathway, which is driven by autoantibody, lectin pathway is driven by polysaccharides or mannose-containing polysaccharides, as would be the case in bacteria. And then the alternate pathway, which presumably is the oldest form of the complement in existence. And this pathway is constantly turned on such that you have hydrolysis of C3 to a liquid form. And then when the complement activates, factor B binds to C3 and gets deposited on cell surfaces. And then ultimately you get the formation of C5 convertase by the series of enzymatic reactions that involve the alternate pathway, leading to the formation of membrane attack complex. Since PNH is a disease that's caused by complement dysregulation, I think it's important to say a few words about the complement. This is a part of our innate immune system that's responsible for removing microbes, non-self particles, fungi, for example. And basically, it gets activated by one of three different pathways: classical pathway, lectin pathway, and the alternate pathway. And the idea is to mark non-self particles by forming or cleaving C3 into C3a and C3b. The deposits end up being on the cell surface, and then ultimately by the formation of what is known as C5 convertase, the formation of membrane attack complex occurs, and that creates holes in the non-self particle, and in this case, it's the red cell that's devoid of CD55 and 59, leading to its intravascular destruction. Now, it's very important to say that in patients who are not treated, intravascular hemolysis is the predominant clinical picture. Not to say that you don't have cells that are coated with C3b, but all those cells that ultimately get coated get destroyed by the membrane attack complex, and therefore having C3b coated red cells tends to happen, although it's not necessarily clinically manifest, because the reason being that those cells get destroyed ultimately. And this is a picture of an electron microscopy of a red cell demonstrating the effects of the forming of the membrane attack complex leading to cellular destruction. We've learned that patients who have PNH have a great degree of variability, as I've already alluded to it. On one end is classical PNH, where you have large clone sizes and evidence of ongoing hemolysis, with intravascular hemolysis being the main component, with propensity for thrombosis. And then on the other end are those patients who have subclinical PNH clones that exist, let's say, in the setting of aplastic anemia, and those clones tend to be very small. The clinical picture is dominated by bone marrow failure. And then, of course, you have a group of patients that sit in between those two extremes, if you will. And so these are data from the PNH registry looking specifically at the clinical manifestation of those patients relative to the clone size. And you can see that patients who present with classical PNH tend to have a much larger clone size as opposed to those who have bone marrow failure with associated PNH clones that tend to have a much smaller clone size. And of course, there are some patients that sit here in between. So characterizing the type of patients that you are dealing with is extremely important. I've already alluded to the fact that we have 3 different pathways to the complement, and it's remarkable to see the progress in terms of therapeutics that we have for this patient population with C5 blockers that were initially introduced in the form of eculizumab in 2007. And then perhaps a decade later, we had ravulizumab. And then more recently, crovelumab. All 3 represent C5 inhibitors that block the activation of C5, and hence the formation of membrane attack complexes is abrogated. And more recently, I think because of the identification of the clinical consequence of C5 blockade in the form of extravascular hemolysis leading to anemia and at times transfusion dependency, the thought was to generate complement inhibitors that are upstream of C5, so hence the development of pegcetacoplan, which is a C3 blocker. And more recently, we had 2 oral agents. Initially, factor B was approved in December of last year, and I will be going over the clinical trials that led to this approval. And more recently, factor D, or danicopan, was also approved in April of this year. So both agents are oral. Danicopan, though, is one drug that is approved as an add-on therapy to C5 blockers, in this case, eculizumab and ravulizumab. So it's actually the advances in the treatment of PNH has been tremendous, and it's all obviously to serve our patient population and hopefully have much improved outcomes. So the very first treatment, as I've already said, is eculizumab. It's an anti-C5 antibody that has the ability to bind 2 C5 molecules, and it's a humanized monoclonal antibody with a murine origin, particularly in the complementarity determining regions of C5. But this drug was taken through a system of clinical trials, including the Triumph trial in PNH, which was a double-blind, placebo or standard of care controlled study evaluating the efficacy of eculizumab in attaining transfusion independence in this patient population. It was very clear that the drug resulted in significant improvement in, or I should say, control of the LDH, which occurred within the first week. This is eculizumab versus placebo. And it was also important to recognize, and that I always try to emphasize this point, that the frequency or the number of type 3 cells, which means that those cells are completely devoid of CD59, increases with eculizumab therapy. And so while those cells are not exactly normal, they are essentially preserved because now you have blocked C5, and therefore those abnormal CD59 missing cells are continuing to exist, and the difference was statistically significant. This is just to show you the type of patients that were enrolled onto this clinical trial. Some of them have lived with PNH for many, many years, and obviously due to lack of effective therapy, and all those patients were transfusion dependent. So the data demonstrated that there was a 51% ability to achieve transfusion independence versus 0% of placebo. So on the basis of the Triumph trial, this drug was approved for the treatment of PNH patients. And because we have the ability to follow those patients for over a decade now, there's also data suggesting that there's an improvement in survival in this patient population compared to historical data that had demonstrated a significant mortality and poor outcomes in people who are diagnosed with this disease. So this is certainly a triumph for patients who have PNH. Now, eculizumab is given IV every 2 weeks, and the idea was to generate an antibody that has longer half-life, and this was in the form of ravulizumab. This drug is somewhat different from ECU in that while it does bind to the same epitope on C5, it has the capacity or capability of dissociating from C5 within the lysozyme in a lower pH or an acidic medium. And then because of its affinity to FcRn, then it goes into the circulation, gets recycled as any other monoclonal antibody would, and grabs more C5 molecules, and the cycle continues. And so this is the reason why the drug has a longer half-life, and it can be given every 8 weeks. The drug was compared head-to-head to eculizumab, which represented standard of care in 2 phase 3 clinical trials in PNH, one occurring in treatment naive or study 301, and one in a switch trial in those who have been on eculizumab. And both trials were non-inferiority, meaning that they demonstrated the fact that ravulizumab is non-inferior to eculizumab, and both trials ended up in long-term extension compartments to follow those patients. So there were few differences between the two studies in that clearly in the treatment naive patients, you're looking at LDH normalization as well as transfusion avoidance, and that was the primary endpoint. In patients who had been already treatment experienced, you're looking at LDH change because those patients came into the trial already treated and having their disease relatively well controlled. And so any way you looked at the two trials, there was non-inferiority was achieved, right? When one looks at the breakthrough hemolysis in the ravulizumab trial, it is evident that the events labeled as breakthrough hemolysis, and in this specific trial, there were breakthrough hemolysis was defined as an LDH over 2 upper limit of normal after prior reduction of LDH, coupled with reappearance of classical PNH symptoms, such as the ones listed. So if you follow that definition, you can see that breakthrough events with ravulizumab were fewer. In fact, none occurred because of pharmacokinetic breakthrough, meaning that if you don't have complete C5 blockade, and hence your patient will present with breakthrough hemolysis. This wasn't the case here, although, again, pharmacodynamic breakthrough related to infections continue to occur with either drug, essentially. So this is something that we need to monitor in our patient population moving forward. The fact that you have fewer breakthrough events perhaps relates to the complete abrogation of C5 activity, if you will, in that the mean free C5 concentration were steadily below 0.5, which means complete complement inhibition or C5 inhibition, versus some degree of fluctuation that is noted in the eculizumab arm. And these data were taken from the treatment-naive trial. There's also some data suggesting that ravulizumab may actually be associated with improvement in survival in a similar fashion reported with eculizumab. Moving on to our third C5 blocker, crovalimab, which was just approved in the United States for the treatment of PNH. This drug has certain characteristics that makes it different from ravulizumab. First of all, it binds to C5, but to a different epitope. So it binds to the beta chain of C5, and that makes it more amenable to targeting patients who may have a C5 polymorphisms. So you have a difference in the part where those drugs bind due to the mutation or the C5 mutation or the polymorphism, and therefore they tend to be resistant to both eculizumab and ravulizumab. So this drug, due to its binding to a different epitope on C5, can overcome this specific problem in patients who have C5 polymorphism. The other interesting part is that you can administer that in a small volume in a subcutaneous manner every 4 weeks. So the pharmacokinetics of this drug are favorable. Why does it have a longer half-life? It too is generated through what is known as sequential monoclonal antibody recycling technology, such that it too dissociates from C5 and then also gets recycled via FcRn, again conferring the fact that you can have a longer half-life. The drug was evaluated in Commodore 1, 2, and 3 trials, and this slide depicts Commodore 1, which essentially looked at patients who had already been treated with eculizumab for over 6 months and randomized them to crovalimab or eculizumab. Unfortunately, this trial, which was intended to include 200 patients, met with some difficulty because of the changing treatment landscape, and hence there were only perhaps 89 patients that were randomized to either drug, and as such, the endpoints were not necessarily powered to detect the difference between the two, and ended up that safety actually was the primary endpoint of that study, and all the others were essentially descriptive. And you can see essentially that you had a very similar responses between both agents, and what you can say is that perhaps crovalimab is non-inferior to eculizumab in this patient population. In terms of Commodore 2, these were treatment-naive patients, and this trial actually accrued 200 patients that were randomized 2-to-1 to either crovalimab or eculizumab, and then we will go through the results of this clinical trial next. It's important to say, relative to Commodore 1, that about 16% of patients who were treated with crovalimab after being treated with ECU had transient immune complex reactions, also known as type 3 hypersensitivity, when switching. And that's because the binding of the crovalimab to a different epitope generated the specific immune complex reaction and resulted in skin rashes, low-grade fevers. But the good news is that these were mostly mild to moderate. They ultimately resolved with NSAIDs or steroids, topical steroids, without treatment modification. But that's something that we have to be on the lookout if considering switching. This is the result of Commodore 2 study in patients who are treatment naive, and the primary endpoint was control of hemolysis and transfusion avoidance. And this simply shows you that in all instances, whether it's primary or secondary endpoint, the trial met its non-inferiority margin depicted here. This is the limit of the non-inferiority as the black triangle, demonstrating that crovalimab is non-inferior to eculizumab in any of the points that are listed. The crovalimab was also assessed in a phase 3 study in treatment naive PNH patients, and this is a study that comes from China. And here you have about 51 patients, and you can see that the majority had hemolysis control. In fact, about half of them had transfusion avoidance. So this is kind of similar, even though it's not compared head-to-head. It seems to be similar in terms of ability to become transfusion independent as a result of therapy. The treatment is somewhat different in that you have IV dosing on day 1 and 4, and then you have sub-Q dosing starting from day 2 on a weekly basis, and then you move on to every 4-week dosing in this specific treatment schema for crovalimab. Now, it became clear after many years of treatment with eculizumab that patients who are treated as such have so-called residual anemia, and some of them are actually transfusion dependent. In fact, in an analysis of over 500 from Leeds from the UK, showed that about a quarter of those patients who have been treated with C5 blockers continue to require transfusion. And then in a different schema, there was an effort to characterize the response to C5 inhibition. And again, in those analyses, which were retrospective in nature, it's clear that some patients attain complete response, which is complete normalization of their hemoglobin and control of hemolysis, and some continue to require regular transfusion and continue to be anemic with a hemoglobin below 8. And a lot of work went into trying to characterize this residual anemia. And it appears that what we have is a process whereby the cells that are now coated with C3b, because you're blocking C5, so now all those cells upstream of that specific complement location, if you will, continue to exist, and they are salvaged due to therapy. But now, because of C3 deposition, they get opsonized and engulf in the reticuloendothelial cells in the spleen, akin to what happens in autoimmune hemolytic anemia, and that is labeled as extravascular hemolysis. And some of those patients can become DAT positive. And remember, PNH classically is a DAT negative disease, but if your patient becomes DAT positive, clearly you are dealing with a phenomenon of extravascular hemolysis, which essentially is an iatrogenic consequence of C5 blockade. So the question became, well, what is clinically significant extravascular hemolysis? And in this case, I will tell you that the various definition of what EVH is in various clinical trials that have attempted to target that specific aspect of PNH. So in general, we think of EVH when someone has anemia, has adequate bone marrow reserve with elevated reticulocyte count, who happens to be on C5 inhibition. And you could simply think about alternate therapies in order to tackle this problem of clinically significant EVH, and considering switching to either pegcetacoplan, iptacopan, or danicopan add-on to C5, or consider enrolling the patient on other clinical trials that look at agents that are upstream from C3 or even factor B and D to see if we may be able to add yet another drug to our armamentarium of drugs to treat the complement in PNH. So let's go on to the first drug that was approved after eculizumab, and that is pegcetacoplan. And pegcetacoplan is a peptide that targets C3 and blocks its activation or cleavage, if you will. And this drug was evaluated in the Pegasus trial, which was an open-label phase 3 study comparing pegcetacoplan to eculizumab in patients, adult patients who had a hemoglobin below 10.5 and despite treatment with eculizumab. And most of those patients tend to be transfusion dependent. They were after a run-in period with pegcetacoplan to attain its desirable PK of a 4-week duration. Then they were randomized to pegcetacoplan monotherapy or eculizumab. And then after assessing the primary endpoint at 16 weeks, then all patients transitioned to therapy with pegcetacoplan. The primary endpoint was change of hemoglobin at week 16. And these are the results of this trial demonstrating that hemoglobin in patients who were continuing on eculizumab actually did not change, whereas those who received pegcetacoplan, you can see the significant improvement in hemoglobin that took place at 16 weeks. And there's actually multiple year follow-up data demonstrating durability of this response. Pegcetacoplan was also assessed in a treatment-naive PNH patient population in the PRINCE trial. And this study looked at 53 adult patients, randomized them to a standard of care, which essentially was supportive care or transfusions. And again, proof of concept, if you treated patients with pegcetacoplan, and obviously here without running, with eculizumab, just simply treatment naive patient, you can attain improvement in hemoglobin as well as control of hemolysis as depicted. Now moving on to the oral agents, and here we have the iptacopan, which is a factor B inhibitor. Factor B is extremely important in generating C3 convertases, so iptacopan blocks the binding of binds to factor B, actually inhibiting the formation of C3 convertases. And you can see the sites actually where inhibition of factor B happens, not only when forming the liquid form of C3b, but also in the activation loop. So, as iptacopan has been shown to be effective in a phase 2 study in terms of controlling intravascular hemolysis, it was taken to phase 3 studies that compared it to eculizumab in the APPLY PNH study, and this is in treatment experienced patients that have been on eculizumab and were randomized to either ecu or iptacopan in this case. Those patients had to have a hemoglobin less than 10 grams per deciliter, and then they were receiving either eculizumab or iptacopan at 200 twice daily. And you can see the improvement in hemoglobin that happened at week 24, after which patients who were on eculizumab were then switched over to iptacopan, demonstrating a very similar improvement in hemoglobin to what was seen in those who were originally randomized to iptacopan. This is the 48-week trial data demonstrating significant proportion of patients that were not requiring transfusions either initially or from week 2 to 48. Similarly, you have a significant percentage of patients that have avoided transfusions in the iptacopan arm, 94 versus 40%. And so the drug certainly demonstrated activity in improving hemoglobin in patients who have been suffering from EVH due to eculizumab therapy. Now, the APPOINT trial was a phase 3 study that looked at patients who were completely naive to therapy, and in this case, they received oral iptacopan. Patients with iptacopan weren't necessarily randomized to C5 blockade in the frontline therapy, but nevertheless, the results were nicely summarized in this very recently published New England Journal of Medicine article demonstrating the significant improvement in hemoglobin at week 24 in the APPLY PNH, or if you looked at the APPOINT trial, which is a treatment naive, and again, significant improvement in hemoglobin. In addition, you can see more transfusion avoidance with iptacopan, whether you looked at the treatment experienced or treatment naive. And this is a depiction of the primary endpoints in the APPLY trial in the treatment experienced, again showing a significant improvement in hemoglobin by at least 2 grams. And then the majority of patients managed to have hemoglobin above 12 grams in both trials. So there's no doubt that this is a highly effective agent. Now, what about danicopan? This is a factor D inhibitor that has been assessed as an add-on therapy to ravulizumab in the ALPHA trial, which is a phase 3 double-blind study that looked at the effects of adding danicopan as tablets 3 times a day to patients who have already been treated with C5 blockers and continue to have evidence of clinically significant extravascular hemolysis with hemoglobin below 9.5 and retic count above 120, who have been on at least 6 months of ECU or RAVU. And then the primary measure of efficacy was change in hemoglobin and an increase in hemoglobin by about 2 grams. And this is the result slide demonstrating improvement in hemoglobin in those who were assigned to danicopan. And then after 12 weeks, those patients that were on C5 blockers were switched over to danicopan, again demonstrating the efficacy that you had seen in those who were originally assigned to danicopan. It's important to see that there was a significant proportion of patients that had increase of hemoglobin of above 2 grams, whether you looked at it at week 12 or 24, in those who were assigned to danicopan or those who switched from placebo to danicopan on the order of perhaps maybe 30 to 50%. And then if you looked at patients who avoided transfusion, that too occurred in at week 12 and 24 with danicopan, or even in those who ultimately crossed over to danicopan. So the majority of patients avoided transfusion in this situation. Now, what's interesting is that despite the tremendous therapeutic advance in PNH, there continue to be multiple other active agents, I should say, despite the tremendous therapeutic advances that happen in PNH as a disease space, there are many other agents that are being currently explored in clinical trials. Silencing RNAs are being considered in a combination with pozelimab, for example, or there are some others, early phase trials looking at MASP3, for example, not to forget mentioning the biosimilars, some of which have been already approved. So it's a very interesting time in PNH. However, we continue to have some challenges, and I remain to see this in clinical practice, in that timing for initiation of treatment of patients who have PNH is something that we need to continue discussing. Residual anemia and potentially increased risk of infection, not only to meningococcal bacteria, but to others, that we need to continue to evaluate this. We need to continue to understand the biology of disorder and what is the risk of evolution to aplastic anemia or myeloid malignancies. And so those are all challenges that we need to be facing in the future and continue to face for this patient population.